First, I would like to thank everybody for this opportunity to present in front of you our Elunier Pearl drug event. I would like to start actually with doing a small introduction on Medanol Group. Since 1992, we have been raising the bar for revolutionary interventional cardiology product and consistently stretching the limits of innovation. Basically, our group consists of Medinol, that is focusing on stenting and catheterization. We have two sister companies that are called Valve Medical, that is focusing on structural heart, working on Etavi, that is aiming for a 12 French and even 9 French access, and Microtech, that is working on implantable microsensors. Our story actually started with the near bare metal stent, which was the first coronary stent longer than 15 millimeters, and the first coronary stent that actually optimized the ratio between the scaffolding and the flexibility, allowing for Professor Colombo in 1995 in Milan to perform the first stenting. He was so pleased with the stent that he actually placed two stents at the first time. We became then market leaders in Europe and the US, and with excellent clinical trials, over 25 studies with over 5,000 patients. Since then, we've been investing in research and development of drug-eluting stents. And today we're introducing the Elunier Pearl, our seventh generation drug-eluting stent. So if I start explaining a little bit on the Pearl, this is the basic ingredients of the stent. So the bare metal stent is a cobalt chromium L605. The coating includes the drug, which is retiferolimus, and we have an inactive ingredient called that is the polymer. It's a permanent polymer that it's actually a mix of two polymers, one the carboxyl and PBMA. The carboxyl is responsible for the flexibility, the elasticity of the polymer, and the PBMA for the drug elution. We have as well designed a unique stent design. We are the only stent in the market that it has alternating strut thickness. So the request from the physicians when we were developing the stent was to get as thin struts as possible. And so what we created is one strut that is 40 microns, that is responsible for the flexibility, and connected to it is a strut that is 72 microns, that is giving the radial strength. And with that, we are actually optimizing the stent flexibility and radial strength. With a most, let's say, reliable bench test data, we have checked it. Our metal to artery ratio provided the lowest in with comparison to other FDA approved drug eluting stents of about 10%. Additionally, we have conducted animal trials to try and see how the reaction of our retiferolimus drug is compared with other drugs in the market. We compared retiferolimus with zotorolimus, everolimus, and sirolimus, and you can see that with retiferolimus and zotorolimus, there is a positive therapeutic window when the inhibition of the endothelial cells is reduced versus the smooth muscle cells. I would like as well to touch a little bit about our unique manufacturing process. So on the left is what you usually see when you expect manufacturing of the stents. This is usually what our competitors are doing. They're taking a tubular metal and then laser cutting it. Our design is totally different. We actually are taking a metal panel and we're printing and cutting it, and we can reach up to 50 stents on one panel. So it's a flat panel. After that, we have semi-automated our manufacturing facility to increase as well our the level of quality that we bring. One of the examples is that once the laser cuts the metal panel, it is automatically checked. Every strut of it is being checked through an automated visualization device that scraps any manufacturing that was done inappropriately. The next phase is our elastomeric coating, which again is coating over a flat panel. The flat panel coating allows us to actually bring a very unique coating that is elastomeric, that can stretch up to 400% of its initial size. So no matter at crimped nominal pressure or rate burst pressure, the integrity of our polymer stays the same with no cracking or peeling. Now, speaking a little bit further into the innovation that we brought with the Elunir Pearl specifically, we have innovated in two areas. We have made changes into our metal spring tip, and we have added the new RadioPEC markers. With regards to the metal spring tip, what we did is we reduced the low tip entry profile. We reduced as well the friction, covering the metal tip with a covered nylon jacket. And we have changed the metal itself to a more radio pack metal. So this way, physicians can easily track the tip of the delivery system is at. So some numbers, just so you can get the dimensions. You can see the 2.7 millimeter tip. You can see that the distance between the tip and the balloon and the balloon marker is around 4.5 millimeters, with a crossing profile of 1.05 millimeters. So these numbers usually are needed when you don't see the tip. With our stent, actually, you will not need to know these numbers because you will have them visible during your procedure. Another added value is that we have no fish mouth effect. So you can see, comparison to other delivery systems in the market, you see that we basically eliminated the fish mouth effect. With regards to our RadioPEC markers, what we did, we actually added two RadioPEC markers, one in the distal and one in the proximal end of the stent. We have added them each one at 90 degrees angulation to make sure that no matter the angulation of the C arm, you will be able to see at least one of the markers at all times. But why is that so important? You see here on the left hand side in the picture, you can see actually the stent markers. You see the proximal RadioPEC markers and the distal RadioPEC markers. But why is that so important? So we're talking about tip. Basically, first you have the tip visibility because we are using the metal spring tip, and this is very good for complex cases like CTOs. With the RadioPEC markers, it's really nice because you can actually use them more accurately when you do osteolesions, bifurcation, and you can use them to have minimal strut overlap when you do full metal jackets. So overall, it allows you to even see the markers with lower resolution C arms. And the overall is to reduce the time and radiation time that you have for you and your patients. I wanted to present to you two case studies, one from Japan and one from Israel, just to demonstrate the added value of the visibility. This case from Japan actually shows a successful PCI of the proximal right coronary artery CTO using a complex bilateral antegrade retrograde strategy. This was done at Sato Hospital. So you can see here, there was a challenging access due to severe aortic tortuosity. The procedure proceeded via septal collateral retrograde crossing. The final The final intervention included full lesion coverage with 3 Pearl DES, achieving excellent overlap accuracy thanks to a clear radiopet markers, restoring of TIMI flow, TIMI 3 flow, and no vascular complications. Here you can see the positioning of each of the stents. You can clearly see here the radiopec markers, and knowing that there is no significant strut overlap as well between the stents. The next case I would like to present is from Israel. It's from Wolfson Medical Center. Here, the case included an osteal LAD with a short landing zone. Need to position the stent precisely to avoid the distal left main trifurcation. So you can see here the stent markers are visible prior to the deployment. So you can see here this is the tip. You can see the balloon markers, and then the internal markers are the stent markers. And here the final result: the stent positioning with less than 1 millimeter accuracy. Here again, to elaborate on how this looks under angio, so you can clearly see the tip, then you can see the balloon markers, and then you can see the stent markers. Again, the visibility really allows for more accurate and precise procedures. Touching a little bit about the clinical update. So the pooled analysis that we have of our Bionics and Neuros trials, the TLF at 24 months, which was the primary endpoint, you can see that it was head to head with Resolute. So you could see that at 2 years, the TLF was 7.0% versus 7.2%, showing a very good efficacy. As well, in the safety area, the definite and probable stent thrombosis at 2 years was slightly lower, especially on the late and very late part. Of course, this was not powered in the trial, but directionally it shows a very good safety profile. On the HBR comparison, you can see that we have a design that we actually took the design from Onyx One and Leaders 3, where the primary endpoint was cardiac death, MI, and stent thrombosis. And you can see that we have reduced, we have excellent results with our primary endpoint. The secondary endpoint, which was BARC 3 and 5, which was bleeding, we presented as well very good results here. So to summarize, we have a unique stent design we call Y-cell, where we have alternating strut thickness of 40 and 72 microns, which allow optimization between the flexibility and the radial strength. We have a unique elastomeric polymer coating that allows to stretch over 400% of its size, allowing for no peeling or of the polymer with our ridaforolimus drug. We have superior deliverability with our metal spring tip, and we added the radio pec marker so you can actually see the stent and increase accuracy. And lastly, our outstanding clinical outcomes with 7% TLF at 24 months and 0.1% extremely low rates of late and very late stent thrombosis at 24 months. Thank you very much.
Thank you, Mr. Uri. Quite a good presentation on engineer. Uh, so with this, I would like to invite Professor Fekre to share his
So, Gaurav,
presentation.
before
Yeah.
moving ahead, we have Dr. Arun with us.
Oh, yes, yes,
Uh,
yes.
and Dr. Arun has also used Elunir Pearl. So, sir, you are a senior practitioner. You have used Elunir also. Will you mind sharing your feedbacks about the brand?
Yes, I think we've been using it now for some time. Ever since it's been launched in India, we've been using it. I think we started the day it was launched. And I agree with the fact that one, it's a very trackable stent. I have used it in small vessels also. So I've used the smaller sizes like 2.25, etc., long length. So it's very trackable in tortuous anatomy vessels. And the other thing is that positioning is very precise. The fact that it has not just balloon markers but also stent markers makes it very convenient to position the stent. So, regardless of the radiation equipment and whatever, stent positioning is indeed very comfortable. And thus far, we've been quite happy with the results. I haven't faced any problems. I've done some bifurcation cases with it also, wherein side branch access has also been very good. And we've had very good results because, again, the positioning using the stent marker in a side branch is very, very simple, straightforward, and effective. So, in those ways, I think it's turned out to be a pretty user-friendly stent. Of course, long-term results we'll get to know in the next few years, but initial results, on-table results have been excellent.
Thank you, sir. Coming from you means a lot. We are happy that you are.
Suboi, we lost you.
We can invite Dr. Deep now. Thank you, Dr. Chopra. Coming from you means a lot. Thanks.
Uh, Thank you, Suboi. And thank you, Dr. Arun, for your valuable feedback. So, Professor Fegre, you can share your screen and let's hear his insights on DCB and Proteach experience.
Can you see my slides?
Not yet, sir.
I think I shared it from the beginning. I don't know if you.
So you have to reshare once again because others were sharing screen.
Okay, let me see. How can
Yeah,
I
you have
do
to do the same process which you did earlier.
it?
Yes, so you can do the slideshow. We can see your screen.
Just a second.
At the bottom, there is a slideshow, right corner. Or yes,
Okay.
yes, perfect, sir.
All right. Good evening, my dear colleagues. It's a great opportunity to be with you tonight in this webinar. I would like to take this opportunity to thank the organizer for inviting me, and I hope my contribution will add to the knowledge and science for this group of expert cardiologists. My name is Dr. Fikri Deeb. I have been an intervention cardiologist since 1986, so I witnessed a lot in the revolution of coronary intervention in general, particularly before stent and now after stent. And I'm glad that we have the drug-coated balloon, which I'm very strongly promoting it. And I'm going to discuss and focus with you today on one of the difficult situation for using the drug-coated balloon, which is acute coronary syndrome. We know that the drug-coated balloon is a drug-free approach to treat coronary artery disease. And when you talk about acute coronary syndrome, you aim to deliver the anti-proliferative drug on the balloon to inhibit restenosis without leaving a permanent stent, which, of course, is not a universal solution till now. However, drug-coated balloon proved good in certain situations, like high-risk patient with diabetes or high bleeding risk. And it is currently recommended for small vessel disease bifurcation. However, for acute coronary syndrome, it's still not the gold standard. However, there are expanding use of these drug-coated balloons in different situations, and we have already some randomized clinical trials which showed non-inferiority of drug-coated balloon when compared to the standard care of drug-eluting stent. And it is not a very popular yet solution for most complex angioplasty, especially in the setting of acute coronary syndrome, especially STEMI and out of hospital cardiac arrest. There are some limited data about the use of the drug-coated balloon in this indication, and I'm going to discuss with you some of these cases. But before we do that, it is very important to mention that lesion preparation is a key of using drug-coated balloon. It's very important to spend the time to prepare the lesion properly. And we have to understand that drug-coated balloon is just to deliver the medication. It's not a tool to do balloon dilatation. Why this is important? Because when you prepare the lesion appropriately before delivering the balloon, you maximize the drug delivery, you prevent early failure, and you reduce the peel-out stenting need, and of course, you ensure optimal flow, particularly in acute coronary syndrome. We have to achieve TIMI 3 flow. We all know the ways to prepare coronary artery lesion, either using a semi or non-compliant balloon at high pressure for fibrotic or fibrocalcific lesions. If needed, you can use some specialty balloons like scoring balloon, cutting balloon. And if the patient has calcific lesions and you need to do debulking or plaque modification, then you need to use whatever you have, rotational atherectomy, orbital atherectomy, or IVL to modify the plaque before using the drug-coated balloon. These are the ideal criteria for proceeding with drug-coated balloon. So if you do coronary angioplasty, you modify the plaque, and you have less than 30% residual narrowing, no flow limiting dissection, TIMI grade flow. If you do FFR and you find it is more than 0.75 or 8, this is a situation that you might consider applying the drug-coated balloon rather than stenting the artery. So it has to be clear that drug-coated balloon would be the last device to use in the procedure, and we aim to do a long inflation. There's some dispute about that. We usually aim to go with nominal, so you have to use 1-to-1 balloon with 40 to 60 seconds at least. And it's advisable to avoid using high atmospheric pressures, so you won't have any damage to the artery, and then you are forced to peel out, stent the dissection. I'm going to show you some cases quickly. This is selected cases. The young patient, 37 years old, with diabetes, dyslipidemia, presented with ST elevation in the anterior wall. And as you can see, there is a critical LAD lesion at the diagonal branch origin with TIMI 2 flow with routine balloon angioplasty for this lesion. And you can see that there is some minimal residual, but no flow limiting dissection. So I decided here to use the drug-coated balloon. And This was the final result. You can see the artery is nicely open, quite minimal residual, very nice result. So I decided not to put a stent here, especially the patient is young. Another patient, 28 years old, gentleman, has absolutely no risk factors apart from social smoking. Suddenly collapsed with sudden cardiac death while he was playing football. He was resuscitated when the ROSC was achieved after one shock for VTAC and brought to the ER. We did the angio for him, and as expected, the LAD was totally occluded proximally. You can see here. So routine primary PTCA here, you can see there is quite big thrombus burden. So we decided to do some thrombectomy, which was very helpful. We removed most of the stent. However, you might appreciate some filling defect here, but because there was no dissection, we tried to crush this thrombus with the balloon. And then eventually I decided to treat this lesion with drug-coated balloon with good result. Still, the filling defect is not gone. I give Agrastat intracoronary. Flow is very good, no dissection, just a small clot left behind. So I decided to treat it with a drug-coated balloon. I put the patient on Agrastat overnight, brought the patient next day for check, and you can see the artery is clean, no clots, very minimal residual, almost a stent-like result with beautiful TIMI3 flow. Other patient, again, was a small gentleman, young gentleman with dyslipidemia and smoking, with a STEMI anterior wall. And you can see again, there was what looks like black rupture with clot burden in the proximal LAD, which again was treated with aspiration catheter. I thought maybe I can just remove the clot, but still this rupture plaque is there, so I did balloon dilatation. And you can see after balloon dilatation, the result was very good, just with a plain balloon. So I decided again to just apply the medicine, and you can see this is the final result. Beautiful result, TIMI3 flow, stent-like, result. I don't know if you have such result. Would you really put a stent? I think I wouldn't. And patient did very well. The last patient was a 57 years old gentleman with hypertension, diabetes, dyslipidemia, and smoking. He came with chest pain and some ECG changes and cardiac enzyme elevation. So he was diagnosed with non-STEMI. And you can see his right coronary was normal, was non-dominant. His circumflex artery comes at an obtuse angle, and you can see there is distal subtotal LCX. Proximal here, there was some narrowing, and also there was some narrowing in the obtuse marginal branch. So I decided to treat this lesion with balloon, and you can see here quite good result after the balloon. So we treated the OM with I just moved the wire from the circ to the OM, treated the OM, decided to use the protege. Actually, this was my first case with protege. I used the drug-coated balloon, taking advantage that it can be used more than once, which is something unique, for this balloon. And I treated the OM first, and as soon as I was satisfied with the result, I pull my wire, put it again in the circ, and I treated the proximal lesion and the distal lesion with the same drug-coated balloon. So I dilated 3 lesions, the OM proximally, this area at the bifurcation of the circ and the distal circ, and you can see the final result. Beautiful result, minimal residual in the OM and in the body of the circ, and the patient did very well. We have in some studies in the literature regarding STEMI patients, this cohort of more than 1,000 patients found that there's non-inferiority for over 3 years follow-up when a group of patients with drug-eluting balloon or drug-coated balloon was compared to drug-eluting stent, with no difference in mortality between both groups. The Revelation study was a randomized controlled trial which showed that the drug-coated balloons only strategy was non-inferior to DES in STEMI patients in terms of fractional flow reserve. So the difference was non-significant, was comparable. There was also the pre-specified analysis of the basket small 2. This is a randomized controlled trial, which again showed a significant interaction between clinical presentation and treatment at 1 year for cardiac mortality and non-fatal myocardial infarction, with lower rates in acute coronary syndrome in treated patients with drug-coated balloon, and the results were continued for follow-up of 3 years. To conclude, my dear colleagues, the benefit of using drug-coated balloon is that you have a stent-free intervention. You don't leave anything behind. That reduces the complication, preserve the vessel function, the vasomotor function of the artery will be reserved, which has also implication on the duration of the antiplatelet therapy with shorter need for that. And that's very important when you have a high-risk patient for bleeding and for diabetic patients and the acute coronary syndrome patient, particularly young patients whom you better avoid putting a stent at this young age. The evidence is growing. We have so far studies showing non-inferiority, but I think that this will keep expanding, and it will be widely adopted technique. And this is my final slide showing my approach, which was published by this group in last year. So if you treat any coronary lesion, you need to prepare the lesion very well by dilating 1-to-1 ratio with a semi-compliant or a non-compliant balloon, depending on the nature of the plaque. If the plaque needs to be modified by rota or lithotripsy, you should do that and then look at your result. If you see no flow limiting dissection, minimal residual or less than 30%, if you want to be more meticulous and want to use FFR and you have it more than 0.75 of 8, then you have a quite suitable lesion to treat with drug-coated balloon only. Very rapid case, nominal pressure, 60 seconds, and you are done. However, if you are not satisfied with the result, there is residual narrowing more than 30%, or there is flow limiting dissection, FFR less than 0.7, you still have to peel this lesion out with stenting and get out with good result. I would like to stop here. These are my references, and thank you so much for your attention.
Thank you so much. Thank you so much, Professor Fikri. I think you have very well shared the importance of DCB, and yes, lesion preparation is the key in DCB. And obviously the cases which you have shared, I can see the ranges of the ages started from very young age, 28 years of the age patient, as well as the 60-year-old patient. So thank you so much for sharing. Dr. Arun, you also have experience Protige in your cath lab. Would you like to any comments on?
Excellent cases, Professor Deep. I would just like to ask your opinion about what you feel is, in your feeling, as the current, set of indications for DCB in your lab. You have already mentioned that most of the guidelines don't support DCB yet in proximal vessels. They support them in distal vessels, smaller vessels, in-stent restenosis, side branch ostia, etc. But what, according to you, are the current potential indications which could be justified on the basis of data we have? And second, I would like you to opine on the role of imaging for using DCB. For instance, where would you think imaging would guide you that this could be an appropriate case for DCB versus DES?
Thank you so much, Dr. Chopra, for these very important questions. If you might allow me go back some years when we started doing angioplasty without stent, the aim of and yani the stent came to solve the two problems we had with angioplasty. The first problem is abrupt closure. When you do angioplasty and the artery close on you, and we used to send the patient for surgery. It was the only solution available at that time on the short term, and on the long term, in-stent restenosis. So stent came to solve this problem. Unfortunately, drug-coated balloon was not available at this time. So what I think is that if in the past the surgery backup was necessary for doing angioplasty before stent, now I think the stent could be your surgical backup. And it's better, in my opinion, to avoid stent if possible. Of course, I agree with you that, for the time being, the indication for using drug-coated balloon is only limited to small vessel bifurcation and high bleeding risk patient. But everything starts with limitation and start to broaden and increase, and the indication become more wide. Same like, TAVI started with a very high risk patient, and now it is done for a low risk patient. So I think this is the trend. This is where it is going. We are still lacking studies, but when I discuss with many of my colleagues, they do similar practice. I know many of my colleagues who believe in using drug-coated balloon and stent only if the result is suboptimal or there is a complication. Now, coming to your question about the using of imaging, yes, of course, it is. If it is possible to use imaging for every case, that would be the ideal situation. But in real life, this is very difficult because of cost. But in certain situations, like left main stem, like very complex bifurcation lesion, I think IVUS is very important, if not mandatory, in this situation, and it has to be used in this indication.
Yeah. Thank you, Professor Pigri. Dr. Arun, any more comments or
I think
questions?
we can move on to the next presentation. There are, I think, 2, 3 more presentations.
Yes, yes, yes. Before moving, I would like to have Dr. Saurav, Dr. Amit, and Dr. Nilesh, your views on the Protige.
Yeah, I had very good experience with Protige balloons.
Yes.
So Yes, it has actually helped us avoid like complex bifurcation situations where we used to use two stents. Now we're using single stent. For side branch, we're using the Proteage balloon. So I would agree that their revolution and more data is coming up. So let's see how things evolve. Maybe we are moving slowly towards a stentless age, but yes, all depends on more data before we can fully adapt it into our practice.
Right, sir. Thank you, sir. Dr. Nilesh, Dr. Saurav, any comments?
Yeah, it's good to use the DV in patients where the branch vessels bifurcation with one of the major branch. We don't prefer the bifurcation stenting, but the steps as told by the sir that lesion should be well prepared, less than 30% stenosis lesion left in the vessels. And I will prefer one comment that I will prefer to do the dab at the last part of the my treatment, so the repeated injection does not lead to more flow limiting convert the flow limiting non-flow limiting dissection to flow limiting dissection. So sometimes I've seen that if we are go for the first the back, if we are doing a two vessel or some branch in a vessel, so keep the depth part at the last one. So it should not there should not be reclosure of that branch.
True.
Thank you, sir. Thank you. Dr. Nilesh, your comments?
Yeah. We have been using recently a lot of Proteus balloons. So we find it very advantageous, especially for long diffuse disease vessels. So as we can avoid using multiple balloons and all. And also because of that wind seal technology, we are not worried about touching the balloon or tracking it in a hurry. So yeah, it's a good advantage. And as we are moving to stuntless PCI, it's going to be, I think, game changer kind of. Yeah.
Thank you, sir. Thank you. So with this, I would like Dr. Nilesh to continue. I'll share your PPT. I'll share my screen. Uh, so just let me know once my screen is visible.
Yeah.
Yeah. So over to you, Dr. Nilesh.
Yeah. Good evening, everyone. Respected teachers, my senior colleagues. I am Dr. Nilesh Chaitanya Reddy. I practice interventional cardiology in Holistic Hospital, Kondapur. Today, I would like to share my thoughts regarding DCB and multivessel PCI. So these are the few clinical trials which I just want to share you. As we know, the DCB has been proven non-inferior to DES in small vessels, and uh, and similar data it has not been studied extensively in randomized trials and all when it comes to large vessels and all which are more than 3 millimeters. So these are the three studies which I found, which they have shown DCBs has been shown to be non-inferior to DES, especially in long diffuse segment disease and also multi-vessel diseases. Next slide. So in situations involving multivessel lesions and those with high burden of stents, deployment of multiple lengthy metallic devices with coronary arteries may impair the restoration of vasomotion in the treated segment. So this compromise can cause stent-related complications including instant restenosis, stent thrombosis, neoatherosclerosis, potentially affecting the feasibility of subsequent CABG surgical options. For multivessel diseases, the PCI target lesions are first determined following balloon angioplasty to assess suitability for DCB treatment. So specifically predation with SC and C balloons and with the vessel to balloon ratio 1 is to 1.0 is mandatory. And post-balloon angioplasty stenting is deferred in all type of dissections. Previously, we used to restrict to type A and type B. Now it is deferred in all type of dissections provided there is TIMI flow grade 3 and PCI with stent implantation without DCB is recommended in cases only if there is a flow limiting dissections with TIMI flow grade less than 3 or residual diameter stenosis which is more than 30%. However, in exceptional cases with normal flow, even though there is no flow limiting dissection and residual diameter stenosis is less than 30%, operator may opt to use DES or DCB if the patient complains of new onset chest pain post-balloon angioplasty, if test changes or progression of dissection is evident. So we have experienced in few cases like that where we had to go ahead and put a stent even though, yeah. So the drug-coated balloon should be inflated to its nominal pressure for for at least 60 seconds. So especially we recently we have started using it in the acute coronary syndromes where it is not possible for all the cases. So we are doing it for minimal 30-second duration. So to ensure it's a full length of lesions dilated with predilated balloons. Yeah, next slide. So coming to the case study, so I would like to share a case. It's a 37-year-old male patient presented with chest pain since 3 hours. So he's a known case of diabetes since 3 years. He was on oral medication. His HbA1c was around 12.0. It's poorly controlled diabetes. His ECG showed non-specific acidity changes. His troponin was negative, but there was ongoing chest pain. Echo showed global hypokinesia. There was no regional almost abnormality, and the liver function was severe. So his hemodynamics were borderline. In view of his ongoing chest pain, we quickly shifted him for angiogram, and then we have loaded him initially, and then we have shifted him for angiogram, and then angiogram showed the LAD tight lesion, diagonal tight lesion. Circ is also having a tight lesion, and RCA is also having a critical stenosis. So we were not sure. Initial plan was to immediately address the culprit vessels. We were not sure which is the culprit vessel. So it was difficult. So then among them, the tightest lesion was the circ. So we have assumed that circ is tight lesion. So we'll go ahead and we'll correct the circ first, and then stage the rest of the vessels, how he improves based on his hemodynamics. So we went ahead with circ angioplasty. Next one. So circ lesion was a bifurcation lesion, where we found both OM and distal circ were large vessels. So initially we have dilated, sorry, yeah. So we have dilated the OM vessel with 2 by 12 NC balloon and distal circ with 2.513. So we commonly use scoring balloons, especially when you are going for a DCB strategy. So post dilation, there was no flow limiting dissections, and there was a good TIMI3 glade flow. Then we have decided to go ahead and do DCB. Next slide. So distal circ we have dilated with 3 by 20 paclitaxial coated balloon, nominal pressures for 60 seconds, and we have done the same thing. We have taken a 3 by 520 paclitaxial balloon, nominal pressures for 60 seconds on the OM. Next slide.
Yes.
So this was the final result. Surprisingly, the patient has chest pain has relieved, and then the hemodynamics started improving. Then we have changed our strategy. So we have decided to go ahead and correct rest of the vessels in the same sitting. Next slide. So for the LAD and diagonal, the similar strategy. So we went and dilated with 2 by 13 for diagonal and 2.75 by 13 for LAD. Next slide. Then we have achieved a good 3 flow, no flow limiting dissections, and we decided to go ahead with drug DCB. And for LAD, we have first used before previous slide. So we have used 2.75 by 25 nominal pressure 60 seconds, and the similar thing for the diagonal 2 by 20 nominal pressures for 60 seconds. Next slide. This was the final result. So there was still some residual stenosis in the diagonal. So, but because there was a TIMI3 flow, and we felt it's a branch vessel. So we said initially our plan was to put a FFR and see whether it is positive or not. But as this is a acute coronary scenario, so we said we will just correct the rest of the vessels, and we will see how his hemodynamics improve and plan FFR study later. Next slide. So then we have addressed the RCA. So initially we dilated the RCA with 4 by 13 scoring balloon, and then we have entered it and did DCB to RCA. Next slide. So this was the final result after using DCB. Next slide. So I just want to compare the angiographic result with angioplasty result. So we can see we have not used any kind of stent, and the results was very good. Next slide. So the angiography was showing tight, significant stenosis, the LAD and diagonal, and the final result was acceptable. So next one. Next one. So over the time, the successful PCA, depth to LAD, RCA, circ, and OM were done. Normal distal flow achieved TIMI3 glade. Normal distal flow achieved in the treated vessels. No immediate procedural complications. Hemodynamically stable. Patient improved clinically over course of time, and after 1 month, his LV function has improved. It has become moderate. And then, so as in this case, we have done triple vessel revascularization using DCB without using any stents. Next one. So although current recommendations for DCB are limited, for small vessel diseases and in instant restenosis. It remains an appealing therapeutic option and to play a significant role in managing de novo multivessel PCL lesions. Advancements in DCB technology, coupled with improvements in imaging techniques, physiological guidance, and adjunctive pharmacotherapy, will also be essential in improving clinical outcomes in CAD management. So, DCB treatment is expected to play a pivotal role, particularly in Asia-Pacific region where patients usually present with small vessel disease or multiple diffuse lesions leading to increased adverse clinical events with DES implantation. Finally, the newer generation bioreabsorbable scaffold development and adoption in future may enable metal-free PCI alongside DCB, potentially leading to changes in the field of PCI and improvements in outcome with patients with vessel PCI. Thank you. Next slide.
Dr. Nilesh, I missed a part in between, but
Yes, sir.
what was the age of this patient?
37 years, sir. Young fellow.
And he was in ACS with cardiogenic shock?
Yes, sir. His pressures, his LV function was only 15%, sir. His pressures were around 80 systolic. His mean pressure was low, but we thought for that LV function it would be okay. But the minute we opened the circ, then his pressure started improving. It became like 90, 95. Then we decided to go ahead and correct other vessels. So initial plan was to just address culprit vessel, let his hemodynamics improve, and plan a stage PCI for rest of the vessels.
Okay. So fortunately, see, your patient did very well, but this is actually not in line with the guidelines at present. The guidelines at present are pretty clear. It is only if the patient is hemodynamically stable, then in the setting of STEMI and multi-vessel disease, you can do non-culprit vessel. But if the patient has cardiogenic shock, then you should do only culprit vessel and leave it at that. So I don't think this is the message which we want to give in general, that you do all vessels in cardiogenic shock, because the guidelines and the data are pretty clear in this regard. So you were fortunate in this case, there was no problem, but this is not what is recommended currently. Anyways, going ahead.
Yeah, yes, sir. His echo was showing global hypokinesia, sir. So we were not sure which was a culprit vessel. So because his hemodynamics improved after correcting circ, so we assumed that circ must be the culprit vessel. So the total vessel correction was also in that. So assuming that we are not sure which was the culprit vessel, because the circ, if the circ was culprit vessel, his LV function was very poor. So we don't know how that circulation has
What was
caused
the
such a severe.
ECG changes? What vessel did the ECG suggest?
These were non-specific, sir. They were not specific to any territory. So they were TVA inversions, ST depressions. They were not specific to any territory.
See, the problem with using this strategy is that you have restored flow in one vessel, which has improved blood pressures. Now the other vessels are flowing. They don't have slow flow or anything. So when
Yes,
you
sir.
intervene in them in the setting of cardiogenic shock, the risk is of getting the slow flow in a vessel which was not affected earlier. And that can
Okay.
lead to secondary hemodynamic worsening and collapse of the patient. You didn't have any standby, any balloon pump also. I mean, you didn't have a balloon pump in place or any, sorry, impella or anything. So the problem is that it is good to achieve flow in the culprit vessel, which has improved pressures, and come out and go back in again on another day. So this session is not on that. So let's not focus on this too much. But this is not the way we would generally approach a case who is in cardiogenic shock. I also have objection on using DCB in proximal vessels in this scenario, frankly. But again, I guess this is not a session for discussing that. But if Professor Fakhri would like to opine on this, we would like to hear his views.
I agree with you. Dr. Nilesh was lucky that the procedure went smooth. If we have any dissection or abrupt closure, the scenario would have been different. I think it is better to stage these cases, or at least use mechanical circulatory support if you want to do multiple visits in the same session. But it is advisable to stage these you could do what you think is the culprit here, and then you can stage this to another session, or at least use mechanical circulatory support. Regarding the proximal lesion, if we are talking about proximal circ or proximal RCA, it is different than proximal LAD. Proximal LAD, maybe if you want to be conservative, you can, stent. If you don't feel comfortable to put the drug-coated balloon. For me, because I have been using balloon for so many years before the stent, I have the confidence to use the balloon. That doesn't mean that I recommended that, but it is my personal choice. And I do that in selective patients, not all patients. If the patient is young, if the patient has high bleeding risk, if the patient has only one vessel, then I select, and the result has to be very good. If you have seen my cases, there was minimal residual. There was no dissection. There was minimal residual. If I have any dissection in the proximal LAD, even if it is benign, if the residual narrowing is borderline, like 25, 30, I might, secure it by putting a stent. But if I have beautiful result, which is almost like the result with a stent, and the patient is very young, I prefer to avoid using a stent, work on his lifestyle, treat him aggressively, and hoping that he will have no need for intervention in the near future.
Yes,
Right. I think all excellent comments. And Dr. Fakhri, what would you think about the role of imaging here in such a case? Since you also accept that we need to have an excellent balloon result, we need to have a dilatation with a 1:1 balloon and good flows before we choose to choose to use a DEB and stop there. So that is why I specifically wanted to know what is your view about the need for imaging in such cases, especially where we are using DCB for proximal vessels.
If I have suspicion, if the patients I have shown were young patients, there was no, geographic suspicion of calcification. The atheroma was soft, also it healed very easily under the balloon. So in these cases, with your experience, you know that the atheroma here with the black is soft, and the need of image here will be just to optimize or to make sure that you have the optimum result. However, if there is diffuse long lesion or calcification, I think the intravascular imaging here will be of value to see if you need to modify the plaque and to optimize the result, and guide you if you are happy with drug-coated balloon alone or you need to stent.
Right. Thank you.
Then, thank you, Dr. Nilesh, Dr. Arun, and Professor Fakhri. So with this, we will move to our next session. I would like to invite Dr. Amit. Dr. Amit, can you share your screen if you're...
Yeah, I'm sharing.
Yeah, sure. Yes.
So my slides are visible, right?
Yes, yes, very much.
Okay, so today I would like to show one case where I used a DCP in a side branch and I converted that bifurcation stenting into a provisional stenting. So before I delve into the case, just quite some small slides regarding the use of drug-coated balloon in side branches. We know it's a modality for non-stent-based local drug delivery, so I'm not going into these details. what I would like to show is that how is like a drug coated balloon better than a stent in a side branch, because if there's no metal, then there's reduced chance of stent thrombosis, reduced risk of progression. It has been seen that in side branches, due to smaller diameter, stents do not perform as better in long term as drug coated balloons. So DCBs have better angiographic and clinical outcomes, and there's reduced target lesion revascularization. So the clinical evidence, there was this meta-analysis published in 2021. It showed that at the drug-coated balloon was compared to a uncoated balloon in the side branch, and it was shown that as compared to a non-drug-coated balloon or a balloon angioplasty alone, a drug-coated balloon had greater lobular diameter at 9 months and less MACE events at 9 months and 12 months follow-up. So this one I told, and then we can see here that outcomes with the drug coated balloons in another meta-analysis, it was published in 2018. It showed better outcomes for the DCB. Here we can, not going to details, lesser MACE events and all those. So DCB was associated with less late lumen loss than the balloon angioplasty. So the clinical evidence for small vessel disease, we know for small vessel disease, the population which is at risk is one who are having peripheral disease, long lesions, or having diabetes or old age of women, where the vessel diameter is around 2 to 3 millimeter. The options we have an uncoated balloon angioplasty, which I'm sure none of us are using. Again, the bare metal, all which have become history. The third option is drug-eluting stents, which many use, and the upcoming one are the drug-coated balloons, which different excipient, different drugs are there. They are better because they have small profile, they promote plaque reduction stabilization, they promote vascular healing, there's low risk for restenosis, and the short duration of dual antiplatelet therapy. So it's a very important consideration because many of the elderly have this small vessel disease, they have diabetes also. So in those populations, it's better if the duration of dual antiplatelet therapy is lesser, so there's less chance of bleeding. So this here we show this again a meta-analysis published in 2022, which I had talked earlier, is that drug-coated balloons were compared with the drug-eluting stent, and at follow-up at 12 months, DCPs had a smaller late lumen loss, and DCPs had a lower risk of myocardial infarction compared to drug-eluting stents, and the major adverse cardiovascular events and all-cause mortality as well as target lesion revascularization and target vessel revascularization were similar in both the groups. So I would like to move to the case without wasting time. So this patient was 71-year male. He had no comorbidities, non-diabetic, non-hypertensive, non-smoker. He complained of angina exhaustion in Weiche class 3. He had syncope 2 episodes for last 1 year. ECG showed bifascicular block. Echo showed no regional or motion abnormality, and the lab parameters were normal. So this is the angio. So angio, you can see here the LCX was normal. The LED D1, it showed a bifurcation lesion. You can see a bifurcation. The side branch is not that big. So it was considered that I thought that I should keep it provisional only. And for the side branch, I thought that I would deal it with a drug-coated balloon. The RCA was non-remarkable. So this is a single vessel disease with branch vessel disease. So the LED and D1 was wired with different wires. And after wiring, this IVUS image was taken. We wanted to see how the lesion in LED was, whether there was much calcium was there or not, or it was just fibrotic. Angiographically, it looked fibrotic only. And we can see here this. So you can see here it is more or less fibrotic only, not much of calcium. It was very tight at some places, like here it's very tight. Some calcium, but even less than 90 degree. So anyway, we first proceeded with dilatation of the side branch with the Proteus 2.5 into 15 balloon. We took the balloon directly. I didn't use a cutting balloon because this case was done it was done around a year back. So maybe today I would have done it differently. Maybe I would have used a cutting balloon, but I proceed with this one with Proteus only, side branch dilatation. We can see here, check shot, reasonable dilatation is there, and for me this result, angiographic result, is okay, because maybe after 9 months, if after a year, if I had done some another angio, the side branch I'm sure would show more luminal gain with time, because drug coated balloon does not act always instantaneously. They act over a period of time. So repeat dilatation with the same balloon. So this is the final check shot for the diagonal. Then we proceeded for the dilatation of the main vessel LED with the 2.5 into 15 NC balloon. Check shot. We took the first stent, 2.75 in 28, and we deployed it. Well, good expansion of the stent, near good expansion. And then the second stent was taken. It was 3.5 in 24. It also showed good expansion. Then the overlapping area was expanded. Here's a check shot. Diagonal is preserved. Fairly preserved diagonal. Then the post dilation was done with 3 into 15 NC balloon. This is the check shot. So we can see here, we did a IVUS run. This is a post IVUS. So we saw that there was a fairly good expansion of the stent. MSA more than 6-7 mm square was there, and it was well expanded and mostly opposed. So I'll just show you the main thing here. You can see the stent struts here, well expanded. So we are like, as far as the LED was concerned, we were like fairly confident that we had a good result. For side branch, I had treated drug-coated balloon, so I was like, okay, it's not a very significant branch for which I have to put a stent. Though angiographically, it looks like we could do something more, but I feel that maybe if I do an angio now, the side branch would have grown. Some post dilation we did, because some areas it was still not opposed, and this is the final shot we took. I'm so sorry, my computer's hanged. Hello?
Yes, sir, we can hear you. Yeah.
Okay.
Yeah.
Sorry. Yeah, so this is the final shot. So what is the take-home message? Clinical outcomes with DCB showed long-term clinical efficacy and safety in treating side branch and SVD. DCBs are associated superior angiographic outcomes compared with DES, and DCB is an attractive and safe option in the treatment of corneal lesions. Thank you.
Thank you, Dr. Amit. Quite a good case. Dr. Arun, any your comments on the case?
Well, I think good case and good result. The only thing I would like to say is, as he rightly pointed out, that pre-dilatation should have been done for the diagonal lesion prior to using the DCB. That's the rule basically, because you don't want to start off with DCB. You want to end the intervention with DCB. So that I think now you do understand. But apart from that, the LED was standard, that had a good result. But I think the most important point is to prepare the vessel well and to have an excellent result before you end the intervention with DCB rather than begin with it.
Sure. Thank you, sir. Thank you so much. So with this, we will move to our last presentation of the day, Dr. Saurabh. Over to you, sir. You can share your screen.
Hi.
So you're sharing your screen?
Yeah, I'm sharing this.
Yeah. Okay.
So, good evening, everyone. Till now, we are focusing on our proteage and DAB for the small vessels, bifurcations, and the young MI thrombotic lesion for the better result without the stent. I am diverting the topic from DAB to the Elunier Pearl. So I have a case. I directly move to a case for a stenting with Elunier Pearl. So my patient is a 63-year female patient. She has a breathing difficulty, and the presentation vitals was pulse was 98, BP 130/80. Her saturation was 90 on room air, and the tropi was strongly positive, 0.65. This was our ECG. Shows the ST depressions between inversions and anterolateral leads, one AVL and lateral leads. But as the patient had desaturation and we done the echo function was fair enough, normal. The X-ray shows some haziness and consolidation. CT was done, showed the fluid level and the bronchus cutoff in CT. So we go on for the bronchoscopy and we see that there is an infection in bilateral lower lobe pneumonia is there, and we done the lavage and the patient get improved. So as the patient get improved, we stabilize the patient and plan for the angiogram. So this was the angiogram, and the left system, that is the LED, is showing proximal plaque with some mid part before the diagonal having the tight lesion, but after the lesion, the diagonal and LED size has narrowly tapered diffusely. So probably the size of the vessel is same as in the distal part, that is around 1.5 to 2 mm only, but the proximal part, mid part, has a tight lesion, and the LED proximal has a plaque. So you can see the in other view also. The circumflex has shown the calcified lesion, which is a tight lesion in a long lesion in the mid part. The RCA has the proximal and distal lesion with the PDA in the distal part adults. So we plan to stent the L6 and LED. So as we see, the L6 was calcified, so we wired the L6 and we tried to evaluate how the calcification calcium is. So we crossing our OCT catheter, but before the lesion we get stuck and we're not able to push out our OCT catheter inside. So we plan to predilate the lesion. We predilated the lesion with the 2.5 balloon and then 2.75 balloon. And this is the post dilatation result. So as seeing the previous case, the less than 30% stenosis can be out for the DAB, but he opted for the calcified lesion for the stent. So we taken the 2.75 28 Elunier, and as we see, we have the landing zone distally in the plaque. So in the just after lesion, we have the landing zones. The help of the marker, we placed the stent in the circummid part, and the stent crossed easily the calcified lesion. So we deployed the stent, and we done the OCT, how the stent is behaving. So this was the OCT run. So you can see the distal part circumflex distal face at the plug there. Now the stent was started. So stent was well upon, but you can see how the stent see in the OCT. You can see the 0.72 and 0.4 millimeter strut differently, and you can differentiate them as told by the medicinal person. So stent was expanded and opposed. So you can see the big struts and smaller struts in between. So there are big struts and smaller struts which can be appreciated in the OCT as per the stent design. Stent was well expanded and opposed. there was still a plaque in the proximal circumflex. There's no dissection in the anterior and posterior part in the edges of the stent. So stent, we dilated the stent and with a 3O balloon, and this was the end result. Now we came for the LED stenting, so we don't have the margin in the proximal part 2 and distal part 2, as the both proximal LED was also stent. Otherwise, you have to put LM2 LED stent, and the distal size of the vessel is very narrow. So we dilated with the 2.512 balloon, and we measure with the balloon the size, and we taken the 2.7512 LM stent. So with the help of a marker, we are able to put a stent at a proper position. That was the beauty of this stent, that we can properly place the stent struts distal and proximal part at the place where we want. So see that it covers the lesion. So we deployed the stent and was dilated with 7.5, and this was the end result. So proximal edge is also okay, and the distal edge of the stent is also okay. So as distal LED is narrow, and we have just a mid part where we have to place the stent and we don't have too much margin. So this stent helped us to stent the red part only. So both the vessels are flowing well, and this was the end result. Thank you.
Thank you, Dr. Saurav. Very interesting case. Thank you for sharing the case. Dr. Arun, your views on this?
Dr. Arun has left because of some emergency.
Okay, okay. Okay, so now I think maybe we can have an
Dr.
open session.
Nilesh,
Yeah.
Dr. Pekri can share their comments after the case is shown by Dr. Bagga.
I would like to ask Dr. Saurav why you started with the circ, not with the LED. This is the first question. And there was a distal lesion also in the LED. Why did not treat this?
So distally LED was only 1.5 and 2 mm disease, and 2 millimeter artery only. After the just lesion the bifurcation. So we don't want to put a struts there in the 1.5 2 millimeter artery size and to take a chance of re-stenosis.
Did you do OCT to the LED?
No, because the size of the vessel was very small.
You
Yes,
might be surprised. You might be surprised if you do OCT and find the size of the artery bigger than what you see because of the diffuse atherosclerosis.
Yeah, we thought for that, but as the whole size of the vessel from after the diagnosis of same size, so we will see the angio again, but the whole LED was of the similar size. That's why we opted the plan for to stand only that mid part.
What is the reason you addressed the circle before the LED?
What is the reason?
You did the circ before the LED.
It's not any both are the critical one. It's just anyone we can do, but the but first plan was that the Austral L6 was plugged, Austral LED was plugged, and the proximal LED has a plug. So we first done the L6. So even if we get the dissection while pre-dilatation, or we change the plan to come to the Austral LED to cover whole part of the LED. That's why we just choice to do the L6 first.
LED is always, we consider it the most important vessel of the heart. And when we have LED and circ, it's always advisable to address the LED first.
Yeah, there is the hostel LED. So if we want to place the stand from the hostel LED, so I will try to first tackle the LCS so we do not hamper the struts of the LED or do not get the difficulty to tackle the L6, and there is no gulpit lesion where this has gone this, and the LV function was good, so we opted for the L6 first.
Okay.
Any
Very good
vasodilators
result.
were given for LED?
Yeah, at that time, pre-dilating post-generation both vessel was given. The artery size was similar
Okay.
because you have seen the whole LED after the diagonal of same size. It's not just tapering out or something like that. From starting to distal, the whole LED of same size.
We had few cases which we tried IVUS, and then we tried cutting and then using DEB for all distal LED. A small size DEB balloon, like treated like a small vessel disease.
But there's
And
yeah, but I was planned if there is a tight stenosis after the diagonal or in the LED. The LED was same smooth caliber, same size, whole LED from the diagonal. That's why I chose it. Otherwise, if there is lesion or tandem lesion in distal part after diagonal, maybe my plan was changed.
okay, few cases we had like this, but after stunting the proximal, after like let us say a few years, once they came for repeat angio, we were surprised actually the distal vessel growth without any intervention. Yeah. So yeah, we never know.
Yeah, definitely.
I'm sure if you did OCT to the LED, you would have found that the LED in this area is more than 1.5 millimeter.
Yeah, definitely. But as the size of the LED after the diagonal is very narrow, it's 1.5. So OCT maybe will tell something better, but maybe it will give result or not, or will be crossable or not.
My idea is if you put a stent in the proximal LED and you still have narrowing distal to the LED, you have some flow limitation. If you improve the narrowing in the mid segment and distal part of the LED, you give the LED territory more perfusion, and it will be better result, But anyhow, the proximal LED looks great, and the circumflex artery looks very good.
We have done the RC later on also. The LED we checked, right? It was the same lab. After 1 to 2 months we have done, but the same size, same thing was as the previous as we left.
His LV function was good, no, Dr.
Yeah.
Saurabh? Yeah.
Thank you.
Yeah. So thank you so much. Any questions or any final comments from Professor Fekre, since we are at the end of our session?
I enjoyed very much the webinar. There was excellent presentation, excellent discussion, very nice cases, different indication for using drug-coated balloon. I would like to thank you very much once again for the kind invitation, and it was a pleasure for me to be with you all tonight. Thank you so much.
Yeah, thank you so much. Thank you, Dr. Saurabh, Dr. Amit, Dr. Nilesh, and all the esteemed doctors. Thank you so much for your time, the great preparing the presentation, sharing your feedbacks and all. And once again, have a good day. Have a good night, actually. Yeah, thank you so much.
Thank you, everyone.
Thank you so much.
Bye.
Thank you, guys.
Thank you, sir.
Bye-bye. Bye-bye.
Yeah, bye.